Hello, my name is Dr. Ramin Kashiyar. I am a pulmonologist and a sleep specialist in Walnut Creek. This video is to give you an overall view of how we evaluate our patients who come in for possible sleep apnea diagnosis. It is not meant to make any specific recommendations, as you have to discuss your condition with your treating physician and they can answer any questions that you may have. Sleep apnea, as I mentioned, is the most common sleep-related breathing disorder that we see in the practice. It is estimated that it affects about 15 to 30% of men and about 5 to 10% of women. The incidence increases in postmenopausal women and approaches that of men of the same age. It is more common in younger Black Americans as opposed to Caucasians, and also the incidence in Asia is similar to those of Caucasians, although the Asians generally have a lower body mass index. Risk factors include age, and sleep apnea is more common in people as they get older. It's more common in men by a factor of 2 to 3 times, as mentioned before, much more common in people who are overweight or have cranial or upper airway abnormalities like large tonsils or what we call a micrognathia, like smaller jaw or other facial abnormalities. More common in people who smoke, who have a family history, and also people who have nasal congestion, who drink alcoholic beverages or use narcotics. The way this works is that as you're sleeping, your muscles relax, and in fact, in REM sleep, most of the somatic muscles are completely relaxed except for the breathing muscle. As a result, the tongue falls back and there's narrowing in the back of the throat that causes obstruction of the airway or initial narrowing. The narrowing results in air going through a narrow passage, causes the vibration, which is the snoring. But if there is complete obstruction and you stop breathing for 10 seconds, we call this an apnea. Symptoms and signs include snoring. It's not very common for people to come in being sent by their bed partners, wives or husbands, telling them that they're snoring so much that they cannot get enough sleep. They have what we call witness apneas, basically. They are snoring and all of a sudden they go quiet, and a lot of times they get elbowed because the bed partner feels that they have stopped breathing and they're not going to take the next breath. They have snorting or gasping. They can wake up with dry mouth. Could have morning headaches in up to 30% of the patients. They feel that they're sleeping 8 hours, but they find the sleeping to be unrefreshing. They have daytime somnolence, a brain fog. They can't concentrate, and they take naps at times. Other conditions would be sleepy driving. There's people who have severe sleep apnea and they can get into car accidents because they can fall asleep behind the wheels of the car. Associated with hypertension, cardiac arrhythmias such as atrial fibrillation. There's a condition called sleep maintenance insomnia, meaning that people fall asleep and then they wake up in the early hours. That could be associated with sleep apnea. Oftentimes they wake up to urinate several times a night, and they're described as having very restless sleeping. 90% of patients who have sleep apnea snore, but most people who snore do not have sleep apnea. The diagnosis cannot be established by clinical history alone. Usually, the non-sleep specialists use a tool called stop bang or other scoring mechanisms to evaluate the risk of sleep apnea. But at the end, testing is needed if there is enough clinical suspicion for sleep apnea so it can be ruled in and ruled out. There is two different major kinds of testing. One is what we call a lab monitored sleep study, where you go to a sleep lab. It's called a polysomnography, and you have monitoring of your brain waves, sleeping, oxygen levels, etc. Your doctor will decide what the best test would be for you. More commonly, we do what we call home sleep studies. Occasionally, the original testing may be driven by your insurance company, which may request a home sleep study before a lab sleep study is done. Most people find the home sleep studies to be much more convenient and comfortable as you sleep in your own bed and in your own home. Home sleep studies can be done very quickly and they're much cheaper than the lab studies. This is one type of home sleep study, and this is called a watch pad. And this is a device that is commonly used in the community. The lab sleep study is much more sophisticated, but it would involve you going to the sleep lab and sleeping there, where you can have your brainwave monitored so we can see the stages of sleep, your breathing, oxygen level, cardiac monitoring, etc. An apnea, we define it as people stopping for 10 seconds. Sometimes I have my patients hold their breath for 10 seconds. That's not a short period of time. If you stop breathing for 5 seconds or 4 seconds, we don't count that as an apnea. Another measurement is what we call hypopnea or shallow breathing, and that has to be over a 10-second period of time, and it has to be associated with a drop in your oxygen level. Together, we lump the score as apnea hypopnea index is the number of times in an hour that you have either stoppage of breathing for 10 seconds or shallow breathing for 10 seconds associated with a low oxygen level. Your doctor may use other parameters called RERAs or REIs to determine the severity of your sleep apnea as well. Once the measurement is done, an index of 5 is normal, meaning that you're entitled to have 5 episodes an hour on the average of stopping breathing for 10 seconds or shallow breathing for 10 seconds. Anything between 5 to 15 episodes, we call it mild. 15 to 30 is moderate, and 30 and higher is severe sleep apnea. Once you get the testing done, your doctor will evaluate you and decide what the most appropriate treatment would be based on your symptoms and the severity of your sleep apnea. Typically, we recommend treatment for people who have moderate or severe sleep apnea, meaning that they have more than 15 episodes an hour of apneas or hypopneas, as sleep apnea could be a cardiovascular and a neurologic risk factor, and also could be associated with cardiac arrhythmias. And people generally don't feel well, they feel sleepy, they feel unrefreshed, they have a brain fog. Untreated sleep apnea could be associated with higher risk of atrial fibrillation. So patients who have AFib, we typically test them for sleep apnea. And if we have a diagnosis, we recommend that they get treated, as if the sleep apnea is not treated and the patient has a procedure to go back in what we call normal sinus rhythm, there's a higher risk that they will flip back into atrial fibrillation if they don't have sleep apnea treated. Mild sleep apnea could be treated non-medically, and whether it's treated or not will depend on your symptoms. So if you have mild sleep apnea and if you have significant witness apneas or tiredness and fatigue or high blood pressure or other cardiovascular risk factors, we typically recommend treatment. For everybody who has sleep apnea, we recommend what we call lifestyle modification, and this consists of weight loss, exercise, side sleeping, avoiding alcoholic beverages and sedatives and narcotics. It's very common when people drink, they snore more. Alcohol is not very good for sleep quality and generally associated with significant increase in apneas. Smoking cessation and obviously avoiding driving or other high-risk activities. The primary treatment for sleep apnea, if we decide to treat it other than lifestyle modification, is CPAP, which is a continuous positive airway pressure treatment. Basically, what this is a device that you put on the bedside table. It's an air blower. It has a hose and it comes to you and it has to interact with you via a mask. And this picture shows a very large mask, but there are smaller masks like nasal pillows or nasal mask. And the way this works is that when you have relaxations of the upper airway muscle and the tongue falls back and causes narrowing or obstruction, this provides an air stent. So there is no obstruction and you can breathe freely. The second option usually is what we call a mandibular advancement device. And this is a specific device that's made by a sleep dentist. And what it does is that it pushes your jaw forward and it creates a little more space in the back of the throat so there is less of an obstruction. It is custom made by a specialized sleep dentist usually. You can buy dental molds online, but these are typically not effective as it takes a few months for the dentist to adjust this so it works. Typically, when you do get a mandibular advancement device, we do a sleep study to follow to make sure that it does work as the device works usually for people who have mild to moderate sleep apnea, so it does not work for everybody. It could be associated with TMJ problems, pain, tooth movements, bite misalignment. I have patients who come in who have these devices and they complain about their jaw being pushed forward and they don't have a good bite. It can also be pretty costly, and sometimes the insurance companies don't cover at all or only cover part of it, but it is convenient. And if it works and people can wear it, it's easy to use. So this is basically a picture of how the mandibular advancement works. So without the mandibular advancement, there's narrowing in the back of the throat, as you can see on the left. And when you put the mandibular advancement in, it pushes your jaw forward and it creates a little more space in the back of the throat where you see the blue line where the air is going without obstruction. Another option is what we call a hypoglossal nerve stimulator, which is an implanted device, and you see this advertised on TV. You'd need to meet certain criteria to qualify, and they would want you to um, fail CPAP, meaning that try CPAP and not be able to use it before they proceed with this procedure. The way this works basically is that it's an implanted device, and this picture is an older version of it. And when you breathe, the device on your chest detects that you're breathing, and there's a wire that goes in the back of the throat, and you don't feel it, but once you start breathing, it gives a gentle electrical stimulus to the tongue and the back of the throat, and when there is narrowing, it causes the muscle to contract and open the airway. And this works for people who are candidate for it. But as I mentioned, it's an implanted device. There are other surgical treatments which are more extreme. There's a procedure called UPPP, which typically we don't recommend and it does not work well. And there's other more advanced surgical treatments which are rarely used. In terms of drug therapy, it's a question that I get asked very commonly. Is there medication? There are several drugs that are being studied. To be honest with you, I'm very skeptical that any drug is going to work very well for this because it's a very complex interaction of muscle relaxation, upper airway obstruction. One thing that we know that works well is medication called tirzepatide or Zepbound, which is approved for treatment of sleep apnea. Is extremely effective. It will take a while for it to work because the mechanism of action is weight loss. And if you are on it for quite a few months, up to a year, up to 50% of people will be, quote, cured of their sleep apnea, end of quote. Unfortunately, although it's approved for sleep apnea, a lot of the insurance companies have exclusion criteria and they don't pay for it. These medications are best used in conjunction with a diet program, and they don't work very well if you just inject the medication and forget about it. So we do have a weight loss program in the office. We highly recommend that you go into a weight loss program. I've had patients who lose 50, 60, 70, 80 more pounds, and a lot of times we test them again and the sleep apnea is gone, but it doesn't work immediately. So if you have significant sleep apnea, would suggest starting treatment and then doing the weight loss medication in conjunction to the treatment. So this gives you a general overview of how we treat the patients with sleep apnea. I hope that you find this helpful, and I would like you to discuss findings with your physician. And if you have any questions, please ask your doctor. And that's it for now. Thank you.